There's a pill sitting in millions of medicine cabinets right now. It's been prescribed by a trusted doctor. It's covered by insurance. It's been taken faithfully every single morning for years. And it may be, quietly, systematically, destroying the brain of the person swallowing it. I'm not talking about some obscure, experimental drug. I'm talking about medications your own doctor has probably prescribed to you or someone you love. Medications for sleep, for allergies, for bladder control, for depression, for acid reflux. These are among the most commonly prescribed drugs in the world. And buried inside peer-reviewed neurology research that almost never makes it out of academic journals and into your doctor's office, is a growing and deeply alarming body of evidence linking these medications to an increased risk of dementia, cognitive decline, and accelerated brain aging in people over 60. This so dangerous. The symptoms don't come with a warning label. They creep in slowly. You forget where you put your keys more often. You lose your train of thought mid-sentence. You feel a little foggy in the mornings. And most people, and most doctors, chalk it up to normal aging. It's not always normal aging. Sometimes it's the medication. My name is Dr. Chester. In my career, I've watched patients get diagnosed with early-stage dementia, only to see their symptoms dramatically improve when we identified and removed a single offending medication from their regimen. I've also watched patients who weren't so lucky, whose cognitive decline had progressed too far before anyone thought to look at what was in their medicine cabinet. That's why I made this video. Not to scare you, not to tell you to stop taking your medications without medical supervision, but to give you the information you deserve to have so you can have an informed conversation with your doctor. Because right now, there is an enormous gap between what the research says and what most patients are being told. In the next few minutes, I'm going to walk you through exactly which 7 medications carry the highest risk for dementia-like symptoms and cognitive decline after age 60. The specific brain mechanism each one disrupts. What the research actually says, in plain English, not medical jargon. And what questions you should be asking your doctor the next time you sit across from them. Before we get into the list, I need to explain one critical concept, the anticholinergic burden. Because it's at the center of almost everything we're going to discuss today. Your brain runs on chemical messengers called neurotransmitters. One of the most important ones is called acetylcholine. Acetylcholine is responsible for memory formation, attention, learning, and clear thinking. When you try to remember someone's name, when you stay focused during a conversation, when you lay down a new memory, acetylcholine is doing the heavy lifting. Now, a large class of medications works by blocking acetylcholine. These are called anticholinergic drugs. Doctors prescribe them for everything from bladder leaks to seasickness, to depression, to allergies. And in the short term, for a young, healthy brain, the effects are manageable. But in a brain over 60, a brain that is already naturally producing less acetylcholine as part of normal aging, blocking what little remains is like cutting the power supply to your memory center. And the research shows that doing this for months or years at a time doesn't just impair cognition temporarily. For many patients, it accelerates irreversible neurological damage. A landmark study published in JAMA Internal Medicine followed over 3,400 adults aged 65 and older for 7 years. Researchers found that people who had taken anticholinergic drugs for 3 or more years had a 54% higher risk of developing dementia compared to those who hadn't. 54%. And the risk grew with cumulative dose. The longer and higher the dose, the greater the damage. That study changed how many neurologists think about long-term medication management in older adults. But it hasn't yet changed how many of those medications are being prescribed. Let's talk about which ones are the worst offenders. Medication number 1, diphenhydramine, the safe sleep aid that isn't. You know this drug by its brand name, Benadryl. It's also the active ingredient in almost every over-the-counter sleep aid you'll find at the pharmacy. ZzzQuil, Unisom sleep tabs, Tylenol PM, Advil PM. It's sold without a prescription. It's cheap. And millions of older adults take it every single night because they can't sleep. Here's the problem. Diphenhydramine is one of the most potent anticholinergic drugs on the market. It crosses the blood-brain barrier aggressively, meaning it doesn't just work in your body, it works directly inside your brain. And it hammers acetylcholine. A study published in the Journal of the American Geriatric Society found that regular use of diphenhydramine in older adults was associated with significantly impaired memory, attention, and processing speed, even after controlling for sleep quality itself. In other words, the drug was hurting cognition above and beyond anything related to the sleep problem it was meant to fix. The cruel irony is that diphenhydramine doesn't even produce good restorative sleep. It suppresses REM sleep, the deep, mentally restoring phase of sleep that your brain desperately needs. So patients taking it are often getting more hours of sleep, but waking up feeling foggy and unrefreshed. Then they assume the fog is just old age. It's not. It's the pill they took to fall asleep. If you're over 60 and using any OTC sleep product regularly, check the label for diphenhydramine. Then talk to your doctor. There are far safer alternatives. Medication number 2, oxybutynin and bladder control medications. Overactive bladder is incredibly common after 60, and the drugs most frequently prescribed for it, oxybutynin, tolterodine, sulfenacin, are among the heaviest anticholinergic medications in existence. Oxybutynin, in particular, has been flagged repeatedly in neurological literature. The JAMA internal medicine study I mentioned earlier found that oxybutynin was one of the strongest individual contributors to dementia risk in their cohort. It crosses the blood-brain barrier at very high rates and significantly reduces acetylcholine activity in the hippocampus, the part of your brain most responsible for forming new memories. That's not a metaphor. That's the literal anatomical region associated with early Alzheimer's disease. Patients taking oxybutynin sometimes describe a mental fog they can't explain, trouble finding words, difficulty concentrating, feeling strangely detached. And because these symptoms can mirror early dementia, they often get written off as the disease progressing rather than as a medication side effect. The good news here is that there are newer bladder medications, specifically a class called beta-3 adrenergic agonists, with the drug mirabegron being the most common, that work through a completely different mechanism and have no anticholinergic activity. They do the same job without touching acetylcholine. If you're taking an older bladder medication, ask your doctor whether you could switch. Medication number 3, benzodiazepines, the anxiety and sleep trap. This category includes some of the most prescribed medications in the world: Xanax, Valium, Ativan, Klonopin, and their generic equivalents. They're prescribed for anxiety, panic attacks, insomnia, and muscle spasms. And they work, sometimes extremely well, in the short term. The problem is that benzodiazepines weren't designed for long-term use. They were designed for crisis intervention, a panic attack, a surgical procedure, an acute anxiety episode. But in clinical practice, millions of older adults have been taking them daily for years, sometimes decades. A study in the British Medical Journal examined over 1,700 cases of Alzheimer's disease and found that people who had used benzodiazepines for 3 months or more had a 51% higher risk of being diagnosed with Alzheimer's. For those who used them for 6 months or longer, the risk jumped even further. Critically, the risk remained elevated even after researchers accounted for the anxiety and insomnia that the drugs were originally prescribed for, meaning the drugs themselves, not the conditions they treated, appeared to drive the dementia risk. Benzodiazepines work by amplifying a brain chemical called GABA, which slows down neural firing. That's why they feel so calming. But chronically dampening neuroactivity in an aging brain disrupts memory consolidation, reduces neuroplasticity, and over time appears to contribute to structural changes in the brain. They're also deeply habit-forming, which is why stopping them requires careful, medically supervised tapering, never abrupt cessation. If you've been on a benzodiazepine for more than a few months and you're over 60, this is one of the most important conversations you can have with your doctor. Medication number 4, proton pump inhibitors, the acid reflux drugs nobody questions. Omeprazole, pantoprazole, esomeprazole, lansoprazole. These are proton pump inhibitors, or PPIs, and they're among the best-selling drugs on the entire planet. They're prescribed for acid reflux, heartburn, and stomach ulcers. Many people take them every single day without ever being reevaluated. PPIs work by dramatically reducing the amount of acid your stomach produces. And that's exactly the problem. You need stomach acid to absorb critical nutrients, vitamin B12 in particular. And vitamin B12 deficiency is one of the most direct, well-established nutritional causes of cognitive decline and dementia-like symptoms in older adults. B12 is essential for the production of myelin, the protective sheath that coats your nerve fibers and allows electrical signals to travel efficiently through your brain. When B12 levels fall, that myelin breaks down. And when myelin breaks down, your brain's communication network starts to short-circuit. Memory slips. Thinking slows. In severe cases, it can look almost identical to early Alzheimer's disease. A study published in JAMA Neurology found that long-term PPI users had significantly lower B12 levels, and that low B12 was independently associated with brain shrinkage, measurable, literal atrophy of brain tissue visible on MRI scans. The particularly dangerous part is that B12 deficiency builds up over years, silently. By the time symptoms appear, a significant deficit has accumulated. And in older adults whose absorption is already naturally less efficient, PPI use can accelerate that depletion dramatically. If you've been on a PPI for more than 6 months, ask your doctor to check your B12 levels. It's a simple blood test, and if your levels are low, supplementation or switching medications may make a genuine, measurable difference. Medication number 5, first-generation antihistamines, not just Benadryl. We already covered diphenhydramine, but the anticholinergic antihistamine family is broader than most people realize. Chlorphenamine, found in many cold and allergy combination drugs, promethazine, used for nausea and motion sickness, hydroxyzine, prescribed for anxiety and itching. All of these are first-generation antihistamines. All of them cross the blood-brain barrier, and all of them carry significant anticholinergic burden. What makes this category especially tricky is that many older adults are taking these drugs without fully realizing it. They're embedded inside combination cold and flu products. They're in motion sickness tablets. They're prescribed for itch and anxiety. The names are unfamiliar. Patients don't connect them to the mental fog they've been experiencing. A study in drugs and aging analyzed the prescribing patterns of older adults in the UK and found that a significant proportion of patients over 65 were accumulating what researchers call a high anticholinergic burden, meaning they were taking several drugs from this class simultaneously, multiplying their cognitive risk with each additional prescription. The alternative is straightforward. Second-generation antihistamines like loratadine, Claritin, cetirizine, Zyrtec, or fexofenadine, Allegra, do not cross the blood-brain barrier and carry essentially no anticholinergic activity. Same symptom relief, dramatically lower brain risk. If you're taking an older allergy or nausea medication, ask about switching. Medication number 6, tricyclic antidepressants, the older generation, nobody retired. Newer antidepressants, SSRIs like Prozac and Zoloft, and SNRIs like Effexor, have largely replaced tricyclic antidepressants in routine prescribing. But a meaningful number of older patients, particularly those who were first treated for depression decades ago, are still on tricyclics like amitriptyline, nortriptyline, and doxepin. These drugs are also used off-label for nerve pain, insomnia, and migraines, and they carry substantial anticholinergic activity. Amitriptyline, in particular, consistently appears at the top of high-risk anticholinergic drug lists published by geriatric medicine experts. Research from the University of East Anglia, analyzing data from over 40,000 patients, found that people who had used drugs with high anticholinergic activity, with amitriptyline being one of the strongest contributors, for more than 3 years, had a 49% increased odds of developing dementia compared to those who hadn't. One of the reasons tricyclics persist in older patients is simply inertia. They were prescribed years ago, they worked, and nobody ever sat down to reassess whether they were still the right choice for a 68-year-old brain versus a 35-year-old brain. They're not the same brain. The risk-benefit calculation is completely different. If you or someone you love is over 60 and taking an antidepressant, especially an older one, it's worth asking the prescribing physician specifically whether the drug has anticholinergic activity and whether a lower-risk alternative might be appropriate. Medication number 7, gabapentinoids, the fast-growing risk. Most doctors aren't discussing gabapentin and pregabalin, sold under brand names Neurontin and Lyrica, are among the fastest-growing prescription categories in the world. Originally developed for epilepsy, they're now prescribed heavily for nerve pain, fibromyalgia, restless legs syndrome, and anxiety. In some practices, they've become almost reflexively prescribed for any chronic pain condition. These drugs work by dampening the firing of neurons throughout the nervous system. That's how they reduce pain signals. But that same neuronal suppression doesn't stop at the spine. It reaches the brain. Research published in PLOS Medicine analyzed nearly 200,000 patients in the UK and found that gabapentinoid use was associated with a significantly increased risk of dementia, with risk rising in a dose-dependent manner. Older patients, particularly those with other risk factors, showed the most pronounced effects. The cognitive side effects of gabapentinoids can be profound: memory impairment, confusion, slowed thinking, difficulty concentrating. These are well documented even in clinical trial data. The problem is that they're often dismissed as side effects the patient should simply tolerate rather than as signals worth investigating. What makes gabapentinoids particularly important to flag right now is that prescribing has skyrocketed over the last decade, often with very little consideration of long-term cognitive impact in older patients. If you've been prescribed gabapentin or pregabalin and you're over 60, the question to ask your doctor is simple. What is the long-term plan? Is this medication being monitored? Are we reassessing whether you still need it at this dose? What you should do now. Let me be very clear about something. I am not telling you to stop taking any medication you've been prescribed. Stopping some of these drugs abruptly can be genuinely dangerous. Benzodiazepines, in particular, require slow, supervised tapering to avoid serious withdrawal effects. This is not a decision to make alone. What I am telling you is this: you have the right to ask questions. You have the right to know what's in the medication you're putting in your body. And you have the right to ask whether a safer alternative exists. Here are the specific questions to bring to your next appointment. 1. Does this medication have anticholinergic activity? That single question, asked directly, will tell you whether your brain chemistry is being affected. 2. Have my B12 levels been checked recently? If you're on a PPI or any drug that affects nutrient absorption, this is a non-negotiable blood test. 3. Is there a lower risk alternative that achieves the same result? For almost every drug on this list, a safer option exists. Second-generation antihistamines instead of first-generation. Newer bladder medications instead of oxybutynin. Non-pharmacological approaches to sleep instead of diphenhydramine. Your doctor may simply not have raised it. 4. Can we reassess whether I still need this medication at this dose? Many older adults are on drugs prescribed years ago at doses calibrated for a younger physiology. A drug that was appropriate at 50 may be excessive at 70. Regular reassessment is not just reasonable, it's good medicine. 5. Can you calculate my total anticholinergic burden? There are formal scoring tools, the Anticholinergic Cognitive Burden Scale, the Anticholinergic Risk Scale, that allow doctors to see the cumulative effect of multiple drugs together, not just individually. If your doctor uses one of these tools and your score is high, that's a real, quantifiable red flag worth acting on. What the research tells us about reversibility. Here is the part I want you to hold on to. For a meaningful number of patients, the cognitive symptoms associated with these medications are reversible, at least partially, when the offending drug is identified and safely discontinued. A review published in Therapeutic Advances in Drug Safety documented multiple cases of patients who had been diagnosed or were suspected to have early dementia, only to show significant cognitive improvement within weeks to months of stopping high anticholinergic drugs. Not all cases, and not complete reversal in every case, but enough to make this question worth asking before you or someone you love accepts a dementia diagnosis as final. The brain, even in older age, has more plasticity than we once believed. Given the right conditions, the right nutrients, the right sleep, the right chemical environment, it can recover, but only if we remove the things that are working against it. Let's bring it all together. 1. Diphenhydramine, found in Benadryl and virtually every OTC sleep aid, is one of the most potent anticholinergic drugs available without a prescription and has been linked directly to accelerated cognitive decline in people over 60. Do not use it regularly. 2. Bladder control medications like oxybutynin have among the highest anticholinergic burden of any commonly prescribed drug. Newer alternatives like mirabegron exist and do not carry this risk. 3. Benzodiazepines taken long-term are associated with a 50+% increased risk of Alzheimer's disease. They were never designed for long-term daily use and require supervised tapering to discontinue safely. 4. Proton pump inhibitors deplete vitamin B12 over time, leading to myelin breakdown and cognitive decline that can look exactly like dementia. B12 monitoring is essential for anyone on long-term PPI therapy. 5. First-generation antihistamines, chlorphenamine, promethazine, hydroxyzine, carry significant anticholinergic activity and are often hidden inside combination medications. Second-generation alternatives are safer for the brain. 6. Older tricyclic antidepressants like amitriptyline remain in use for many older adults and carry some of the highest anticholinergic risk scores of any class of drugs. A reassessment conversation with your prescriber is warranted. 7. Gabapentinoids, gabapentin and pregabalin, are being prescribed at unprecedented rates and are associated with dose-dependent dementia risk in older adults. Long-term monitoring and regular reassessment are critical. The most powerful thing you can take away from this video is not fear, it's agency. You are not powerless in this. Your brain health is not entirely out of your hands. The conversation you have with your doctor next week, the questions you ask, the alternatives you request, the reassessments you insist upon, those things can change the trajectory of your cognitive future. You've spent a lifetime building the mind you have. It's worth protecting. If this information helped you or someone you care about, please share it. More than 55 million people worldwide are currently living with dementia, and many families are watching their loved ones decline without ever being told that the answer might be sitting right inside the medicine cabinet. The more people who see this information, the more lives it can change. Subscribe so you don't miss upcoming videos on how to actively protect and rebuild cognitive health after 60. The evidence is out there. You just need someone to translate it for you. This video is for educational purposes only and does not constitute medical advice. Never discontinue a prescribed medication without consulting your doctor first.